You may have heard the words pelvic floor. Yet, do you know what it is? And do you realize that if you're human, you actually have one? And like most body parts, if it's working well, you don't even think about it. Yet, if your pelvic floor is affected by disease, treatment, surgery, or even weakness, it can become a huge quality of life issue. In this episode of the Recovery Room podcast, we are talking about the female pelvic floor. Today on the show, I bring you nationally respected pelvic floor specialist, Erica Vitek. We are going to describe the pelvic floor, where it is, what it does, how it can be impacted, and if yours is, what you can do about it. Bladder leaking, aka incontinence, of any level is not normal. It's important to point out, though incontinence may not be normal, it is still fairly common. So if you have a pelvic floor, and you do, bottoms up, this is going to be a good one. Whether you are podcast watching or listening, I appreciate you being here. I'm cancer physical therapist, Dr. Leslie Waldke. Please hang around until after the show to learn how you and I can engage directly in my incredible cancer survivor community membership group, Recovery Room Plus. This is the Recovery Room podcast discussing all things cancer and cancer recovery. We bring you the experts, accuracy, understanding, and next steps you need to be healthier, more confident, make better decisions, and live your best life after cancer. Hello, everyone, and welcome to the Recovery Room podcast. Today on the show, I am glad to introduce you to a colleague of mine who I've worked with alongside of for, almost 2 decades. Erica Vitek is an occupational therapist and a nationally respected pelvic floor specialist. And today we are talking about women's pelvic floor. What it is, what can go wrong, whether it's just from a cancer diagnosis, cancer treatment, endometriosis, or hysterectomy, where we're going to talk all things pelvic floor, pain, incontinence, even fecal incontinence. None of that stuff is normal. So before I say hello to you, Eric, you will resoundingly agree with this, that incontinence, which we'll start with, is not normal. It is not a normal part of aging. So if it's happening to you, whether it's resulting from cancer or some other kind of surgery, or just because whatever, it's not normal. Pain with urination, pain with a bowel movement, pain with intercourse is not normal and needs to be addressed. And you deserve to have it addressed. I'm glad we're talking about it because it's kind of not necessarily touchy and it's not taboo, but it's not something that people are just going to have a conversation at the lunch table at work, So it's important that we're talking about this because people deserve help because it's a medical problem. There are established evidence-based treatments for these things. And that's what we're talking about today. So Erica Vitek, welcome to the Recovery Room podcast. Glad to have you here.
All right, Leslie.
So this is pretty common, is it not? I mean, not everybody has these issues, but it's not like it's 1 in a million. This stuff happens to people.
Yes, very common. In fact, probably more common in women than in men.
Okay.
We should do something about it because there are strategies to make the quality of life much better. So yes, very, very, very common to have these issues, but also very common to help these issues.
Okay. All right. So let's just start, because the pelvic floor has been part of the human body since the human body came into existence. But really, when we were younger, it wasn't part of the anatomy that we learned, or it wasn't part of the lexicon in biology school. So can you just give us tell us what the pelvic floor is to start with?
Absolutely. Yep. So you think about your trunk muscles, your ribs, and then down to what we call the pelvis. So the base of your trunk.
Yeah, that big bony thing, your pelvis. Yep.
Mm-hmm. Yeah. So the base of that is the pelvic floor. So it goes from the front to the back of your pelvis. It forms like this bowl or sling or hammock at the base of the pelvis and attaches to the front, which is the pubic bone, and to the back, which is like your tailbone in the very back. And basically that muscle supports all of the organs that are inside. So you have your bladder in the front. The uterus actually sits just on top of the bladder, kind of like over the bladder, like so. And then behind that, the colon rectum, where we have our stool in the back. Okay. And so the pelvic floor itself has those openings surrounding the urethra, which is the tube that exits the bladder. the vaginal canal, which is exiting the uterus, and then the anal opening, which is exiting your rectum.
Okay.
And so there's those three openings, and
excuse me.
basically goes in like a figure 8 around all of those openings.
Okay.
And so that can then be closed. We can tighten it, tell it to tighten or squeeze it, or we can then relax it. And the pelvic floor also just maintains, just like our posture during the day, it helps us just maintain holding everything in, just supporting us.
And I will say that, if you have a knee surgery, you have to rehab your quadricep muscle and your hamstring muscle, right? And if you have a rotator cuff surgery or a hip surgery, you have to go to rehab and rehab those muscles. You wouldn't have surgery without doing that. That's just standard of care. But when people go through surgeries that impact or treatments that impact their pelvic floor, sometimes that natural flow isn't there. And people, so that's why I say, if you are experiencing anything, and again, we've recorded a completely separate episode for these issues in men, because it's the same boat for them, right? That these symptoms are not normal. If you're having them, you should seek out medical attention, whether it's your primary care physician, your gynecologist, your medical oncologist, it doesn't matter. And they should follow up with doing something. So if you feel like you're not being heard, then go on to the next physician or a nurse practitioner or somebody that will listen to you, because it's not normal to not be normal. So let's just get that right out there. So, all right. So we've talked about the pelvic floor being basically a sling of muscles. Okay. Because you think about it, the bottom of your pelvis is a hole. There's nothing there. So what holds everything in is those muscles. And if those muscles aren't in great shape, you're going to have issues. You strengthen those muscles, you help make those muscles healthier, you're going to have fewer problems. So can you now just define what does urinary incontinence mean? What does that mean?
Yeah. So it's basically an involuntary or leakage of urine that you weren't expecting or aren't
or don't want
permission to.
Right.
Yeah, exactly. So there's a couple different types of urinary incontinence. So stress incontinence would be like your typical, you cough, you laugh, you sneeze, you bend over to lift something up, that kind of thing, and you leak a little bit of urine. So that's stress incontinence. So that's pressure from your abdominal area onto your bladder.
Pushing down. Yep.
Is a little urine out. Okay. That's stress incontinence. Urge incontinence would be the gotta go kind of feeling, and you gotta really rush and you don't quite make it in time, and a few drops come out or something before you make it there. Or sometimes people will have like a full, leakage of their urine. And then there's something called mixed incontinence, and that would be a combination of both the stress incontinence and the urge incontinence. So maybe you have a little bit of both or experience both types of symptoms, which we can address as well. And then there's sometimes if you have trouble like emptying your bladder, which is a whole different issue. Retention, you might get something called overflow incontinence, which means your bladder is overfilling and you will have leakage from that. So there are ways to figure out what type of incontinence you have when you come into the clinic, or your physician may already know that before you come to pelvic floor therapy. We can figure that out for you as well.
Okay. All right. So, people that may be affected by this. First of all, if you don't have had it, if you've had none of these surgeries and you're having some of these symptoms, call your doctor, because we can get it evaluated and get referred to. And again, a pelvic floor therapist. Most places in most communities now have them. That may be an occupational therapist, maybe a physical therapist, but there should be somebody around that can help you, even if you have to drive a little bit. But people with cervical cancers, pre-surgical lesions, endometriosis, post-hysterectomy. Another huge population is people with breast cancer who are estrogen positive, who then go on anti-estrogen medications that can affect the function of the urethra and the pelvic floor. So those people fall into these categories a lot. So anytime you have any of this stuff, again, sex shouldn't hurt, defecating shouldn't hurt, urination shouldn't hurt, and just you shouldn't have pain there in general. So if you do get in to have it taken care of. So, all right. So that kind of gives us an idea of what the pelvic floor is, what incontinence is. And if somebody's noticing something, their first phone call should be to, as I mentioned, one of their physicians or their nurse practitioner or advanced practice nurse, so they can check out other things, make sure that you don't have an infection, that your blood pressure is okay, that it's not a medication or some other weird thing that they need to just make sure that that's okay, and then make sure that you get referred to a pelvic floor therapist, because again, none of this is normal. So if somebody's diagnosed and they get sent to a pelvic floor therapist, what can they expect on their first visit? What are you going to do?
Yeah. So first, obviously get some introductions of really what's the story? What's the story behind how this started? Was this because of a surgery? Was this because of you had a baby? Is it because of a cancer treatment or cancer diagnosis? And we just really want to hear the story. I want to understand what the person's been through, how this all came about, because it can really help us attack what's the real factors that are involved. And then I just want to hear more details, about how many times do you go to the bathroom each day? How many urges do you get that are uncontrolled, like leakage? How much leakage do you have? Do you have to wear a pad? Do you have any burning with urination? Do you have any pain with urination? Do you have to push to urinate or strain and use effort? Are you getting up at night to go to the bathroom? We can work on that. You shouldn't have to get up at night. Maybe one time a night. As we get a little older, that might be a little more common, but it's still something we can work on and help with quality of life. So I want to understand like the history and the bladder kind of characteristics, like what's really happening with you. And then want to understand the bowels as well. Constipation can cause bladder issues. So I want to know, are you having a regular bowel movement? 3 times a week is still considered normal, but really daily is most comfortable for most people. And we might want to work through how can we make that a little more frequent for you. But if it's less than 3 times a week, then we really got to work on it, and we can work suggestions.
Because it's most likely in that case it's causing symptoms.
Yeah.
Or making symptoms worse.
Yeah. Okay. Yep. And so we want to understand, what's the consistency of the stool? Is it real loose? Are you having like fecal incontinence or urgency to get to the restroom? Are you having more of this hard stool that you can't pass, that you're straining or using a lot of effort for? Do you have hemorrhoids or bleeding, or is there anything else more that you can tell me about? Abdominal symptoms, bloating, things going on in the abdomen, cramps, things like that. We can talk about all that and do something about some of those things too. And then I want to understand the sexual health aspect of things. So for women, I talk a lot about, penetrative intercourse, or, what kind of relationship are they in? So I can really understand their sexual history and what their needs really are. Do they wear tampons? Do we have to deal with what kind of menstrual products? Because maybe their skin is sensitive too, or just things like that. There's a lot of different things out there that we can suggest to help with those things. Is there pain with a medical pelvic exam? So I want to understand like their experiences with medical exams as well, because that could be potentially part of what I would do in the session. It wouldn't be medical; it would be more musculoskeletal. Since we're therapists, we work on the muscle aspect of things. So we'd be examining muscles. So I just want to understand where the person is at with sexual health. If there is penetration into the vaginal area, is that at the entry? Is that deep? Like I need to understand it. Is friction? Is there dryness? Like what's really going on? So we can get into those details. And then I want to understand what does that person drink each day? What do they eat? Do they have any allergies to foods or sensitivities to certain foods? What is their exercise program like already? Like what are they doing for exercise? Have they tried pelvic exercise? Do they do the aerobic exercise? Do they keep active, do strengthening, those kind of things? And what is their sleep like? I want to understand all those kind of pieces of quality of life. And then from there, what I usually describe then is use a pelvic model of the female pelvic floor. We have the bony pelvis with the musculature there, and I can explain how the bladder, the uterus, and the rectum and colon areas all lay out there, and how the muscles affect someone's ability, someone's pain condition, someone's incontinence, how it all goes together. And then
I tell you, just looking at that makes it so much more understandable. It's like, wow, this totally makes sense. So if you're on the fence, like, I don't know, I don't get all this stuff. Again, just come in and talk to somebody, because it will really make sense once you're done. It really, it's incredible to see that 3D model. And then it's like, oh, now I get it. Now I get it.
Sometimes awareness, Leslie, as you know, is like half the battle, right? Just being aware of our bodies and understanding it can be just huge.
That's huge.
And then from there, depending on the person's comfort level, I will suggest different assessment type things we can do. So I have different internal techniques that I'm trained in that I can present and explain how we can palpate some of the muscles, and I can really understand what's going on vaginally for them, or anorectally, or even externally. We can do some palpation externally as well if needed. We also have something called biofeedback that uses either internal or external sensors. So it kind of looks like a tampon that can go internal, or with females, I can also assess anorectally with a sensor that's about the size of a pinky. So it's not too bad, but some people don't feel comfortable with those things. I present the options for assessment. And again, we can also do just clothed assessment as well if someone doesn't feel comfortable or confident in taking off their undergarments and things like that. So we have lots of options to try to figure out what's going on. And I like to just present them all, and then the person can tell me what they'd like to do.
Yeah, I think that's perfect, because I think that is probably a main reason people don't want to go, right? But so I want people to hear your words very loudly, that a physician, a nurse, a rehab therapist will present you your treatment options, okay, or diagnostic options. You choose which ones you say yes to and no to. It is always informed consent. Patients are always in control. So if you are not comfortable with something, you just say, I'll do this and this, but I would prefer not to do that. Maybe next time, maybe never. But a good therapist, that's no problem. So please don't let that keep you from going into talking to somebody.
There's definitely ways, Leslie, that I can teach people how to examine themselves at home using a handheld mirror, different positioning techniques they can use to really look at their own pelvic floor if they don't feel comfortable with me doing it. So it's all about that give and take of the education, so I can help somebody understand what they should be looking for if they're not comfortable with having me do it at that visit. They can always change their mind or let me know, like at a later date, like I need a little bit more help or guidance. And we can change plan at any time. We can do more or do less at any time in their treatment.
Yep. And I'll also remind people too that we in healthcare, or we in physical therapy or occupational therapy, we're asking people to do things sometimes that either are uncomfortable or hard or painful. And again, we may not have the condition that you've had, but we've as humans, we've been through, when we learn on each other. So we kind of get an idea of how things feel and how uncomfortable it is, and so we can't put ourselves in your shoes, but it's not like we're just saying just do this because it's what I'm telling you to do. I mean, we get it, and again, you want to be able to have a good relationship with your therapist, just like you want to have a good relationship with your physician and nurse. So if you're not clicking, then ask for somebody else. So what else is on your list of things that you can do for them, or they can do at home? Both.
Yeah. So after we get all that assessment data, treatment, obviously we want to work on stuff, right? So pelvic floor exercise. So I'm always working with people on understanding how that works, because sometimes it's mysterious on how to squeeze and relax their pelvic floor. So we talk a lot about how to do that. We work on manual therapies a lot of times. So abdominal manual therapies, pelvic floor manual therapies, if they would like to work on that, or I do some self-teaching for how to do that on their own. Internal type manual therapies. There's lots of tools for stretching comfortably and to progressively stretch the area. Say they need vaginal dilators or anorectal dilators or different tools like that. So there are a lot of different ways that we can stretch or work those muscles, or make more comfortable, like deal with pain conditions or discomfort or scarring from surgeries, where we can more gently stretch it and get the body used to touch there again. Because sometimes there can be, sensitivity after some of these treatments, right? Or dryness of the vaginal area. So, I talk to people a lot about like lubrication and moisturization and estrogen and things like that, that they can use to help make themselves more comfortable.
Yeah. So we'll talk about that in a second, but you've also mentioned now that dry needling has become very popular because it's evidence-based. It's like, wow, really, it works great for the rotator cuff. It works great for the upper neck. It works great for the hip. We're now getting evidence that it's very helpful for the pelvic floor, both in men and women. Can you tell us a little bit about that?
Yeah. So dry needling is really an outstanding intervention that gets directly into your nervous system. So what it uses is a little needle that looks very similar to an acupuncture needle, a little bit longer in length because it gets into the muscle belly directly at the nerves and at the muscle itself. And so we can communicate via this needle into your nervous system to produce all of these great chemical responses of your body for healing and regulating function of the bladder, function of the bowel, and dealing with pain conditions. So pelvic floor dry needling, just like you said, Leslie, we can use it on other muscles, and the pelvic floor is a muscle too. So we can use it right in that area as well.
Yeah, that's really cool. All right. So when it comes to either folks that are older and are like postmenopausal and losing a little bit of body estrogen, or people who are on, they may be 30 years old, but now on anti-estrogen medications for estrogen positive breast cancer. So let's talk about the difference between lubrication, moisturizers, balms, because they all act a little bit differently. They're for different things. Yes. And just to caveat this conversation, so if you have an estrogen positive breast cancer, in the past, it has been an absolute, stop to do not use topical estrogen creams in your vaginal area. Okay. And we've now learned with evidence that that's not necessarily a hard stop anymore, that using an estrogen cream occasionally is not, there's not enough if it gets into your bloodstream to impact your hormonal levels at all. So still always recommend a conversation with your physician, but there's a 90% chance they're going to say, go ahead. And if they say no, then say, well, are you up on the most current evidence I'm hearing on the street is that actually is okay. And then they can look at it, or again, talk to your gynecologist, talk to your medical oncologist to find out what's best for you. But the nice thing is that the allowance for those things has gone way up because boy, they can be game changers for some people. Yeah. So anyway, lubrications, balms, moisturizers, what's the difference and when would you use one versus the other?
Yeah, absolutely. So the lubrication is usually used for sexual activity or using some of the tools that I was talking about to stretch. Okay. Yep. So it's really to lubricate the area so it's more comfortable to move a tool in and out, to move your finger in and out, to have relations with your partner, those kind of things. So it's really a kind of a temporary thing to lubricate the vaginal area or externally to make it more comfortable to do your therapy or to have relations with your partner, right? Okay. Then there's moisturizers. So day to day, if you just feel really dry down there and it's like, this isn't good, it's chafing or it's itchy or something's really bothering you, there are a whole bunch of different moisturizers out on the market, or balms that just kind of like soothe the area. So you can use like a balm or a moisturizer to just as a daily routine, kind of like you'd put lotion on your hands. Yep. So a good lotion seals it in, and when you wash your hands, it doesn't necessarily all come off. And so that's kind of the idea of moisturizing. So that's different than lubrication. Estrogen, on the other hand, actually rebuilds the wall of the vagina. There's also estrogen receptors in the urethra and at the bladder base. Yep. Which is why some of these treatments or menopause can, decrease to estrogen affects the urethra, and which can affect continence. So that's why sometimes those kind of go hand in hand. So, all right. So estrogen, you're talking about estrogen creams actually can not just help symptoms, they can fix some of the problem. Yes, exactly. Okay, that's cool. Building the wall, make it more thicker, make it more resilient to friction or touch or even clothing on the area, the whole 9 yards, and incontinence. So it can rebuild some of that support of the connective tissue in the pelvic area to help with support of the urethra, the bladder, the vaginal wall, the whole thing. So really,
and that is a prescription from your physician.
Correct. Exactly. Yeah. Usually, now this is obviously physician dependent, but usually they'll have you use it like every day for a short time, maybe 7 to 14 days, and then you go on kind of a maintenance. Where you use it every 2 days, every 3 days, depending on your physician's recommendation or pharmacist's recommendation. And a lot of that is because estrogen is held into some of the fatty tissues there. So it lasts for a few days. So once you get yourself up and running on it and you've had some initial benefit, then you can kind of go on a maintenance dose after that.
Oh, that's awesome. That's awesome. Do you have like three top resources or a handful of resources that are some of your favorites that we can share with the audience?
Yeah, absolutely. So intimaterose.com is run by a physical therapist. I use her resources, probably one of the most. She has the tools for pelvic rehab that you can purchase that are very well put together. She has great items. She's got velvet rose lubrication. She's got this balm, the vaginal balm, and everything that she seems to have is very well made and very well put together. And she's a PT, so she's kind of got that rehab mindset for her items.
There's education on that site as well?
Yes, she's got some videos. She's got some handouts. Yeah, she's really great at also explaining use. So you can have reinforcement. You get your education from your therapist, but then she can help reinforce how to use things that way. There's also something called the pelvicfloorstore.com, and that's run by a physician. And she is outstanding in regards to just having the gamut of everything you can think of for pelvic health. So her resources are outstanding as well, and has really great reviews of her products. She's very particular on what she puts on there, but it's a really nice one-stop shop for many, many things on her website. And then just kind of thinking about other tools. There's something called CMT Medical. They have some other great tools. So for example, if someone's experiencing a prolapse, and we didn't mention that quite yet, Leslie, but if someone has like some dropping or some kind of coming down of their tissues in the vaginal area, there's a lot of things we can do in pelvic rehab for that. And sometimes it's a lot of pelvic floor strength, but other things, there's some tools for helping people evacuate stool a little easier if you have like pocketing, and different kind of medical tools there that maybe a therapist could direct that person to. So, but it's nice to be able to check that out. They also have different garments for like support. So if you feel like heaviness or pain, they have like the FemJock or the V2 vulvar support. So there's different things you can wear to make yourself feel more comfortable, and different products that way too that they have there. And then just one last thing, Leslie, is a lot of times I do talk a lot about like mindfulness and just kind of connecting with the body. And Carolyn McManus, McManus, Carolyn McManus, she's a PT. She has free meditations on her website. It's the 4 different types of meditations that are 10 minutes long. It's usually my first go-to to have someone try out what would mindfulness feel like to me, because some people just don't really want to try it sometimes. They're like, I don't really got into that. But she has just these great little 10-minute free little mindfulness, and there are different techniques and ways of going about it that if you listen to them and try it out and just see if it helps you to get a little bit more relaxed, because that can be so related to pain conditions in the pelvic floor, in the abdomen, bloating, cramping. If you just work on some mindfulness, some breathing techniques, muscle awareness, it's just a great way to start. And then from there, there's so many places you can find mindfulness things, but this is just a great way to start free and to really give it a try.
So, well, those are incredible resources. Thank you, Erica. And again, reminder, guys, you can find all these resources in the show notes. So as we wrap up, Erica, the specialist of all things pelvic floor, any major myth you want to bust, and final closing words for our audience?
Yeah, I think the biggest one to reiterate, Leslie, is aging does not mean you have to live with these things. We can do something about it even as we're getting older. We really need to work with our body. It's a huge quality of life issue. We can really do something about it. So let's not let age get in the way of getting help for these things. And like you brought up the estrogen, there is a lot of just concern behind that. And I think those are like the 2 main things that I come across the most in the clinic as far as myths or things that we should really dig into or get people into the clinic to discuss more about. Again, just because these things are common doesn't mean that they're normal. And just because they're common doesn't mean that we can't make them better. Because again, the quality of your life matters immensely. It does. We all get to from point A to point B, and it's a hell of a lot better to get to point B a lot less miserable. So definitely talk with your physician, your nurse,
and get in to see a pelvic floor therapist if that's what you need. And if you don't know if that's what you need, go see one and they will let you know. If they're not going to treat things that aren't there. So they're like, you don't need this. You need something else. Maybe you're going to send you to a hip person. You need a little bit of rehab therapy or pelvic therapy, or you need a lot. But you're never going to know until you ask. And again, it's a safe place by an evidence-based professional. So really encourage you to seek that out. Erica, thank you so much for joining us. Love your expertise and love your brain and your passion. And thank you, everyone, for joining us on the Recovery Room podcast. Care for yourself well. You are the most important person on the planet, so treat yourself like that. And, of course, exercise like your life depends on it, because it does. Thanks, everyone. We will talk soon. Good night. Before we jump into your recap, I want you to know that I love having you in my community. So if you haven't already, please follow and subscribe to the Recovery Room on YouTube and Facebook, and to the Recovery Room podcast. Please share these wonderful free resources with your support groups, family, friends, and your medical teams. I also have an incredible cancer survivor community membership group called Recovery Room Plus. I'd love for you to consider joining. In Recovery Room Plus, you get direct interaction with me, in-depth cancer recovery info and experts, and really cool live events like yoga, book discussions, cooking demos, member meets, and much more. I would love to connect with you. You can learn more at recoveryroomplus.com. The link is in your show notes. And here is your episode 8 recap. We learned that incontinence is not normal and is not a normal part of aging. Your pelvic floor is the sling of muscles that makes up the floor of your pelvic bones. These muscles support all of the organs in the area. We defined stress incontinence, urge incontinence, mixed incontinence, and overflow incontinence. If you are experiencing leaking, pain, or any symptom, please don't live with it. You deserve to be healthy. And you know what? Yes, these issues are common, but so is treatment. These are the steps to follow. Acknowledge that there's an issue and that it's not okay. You deserve better. See your medical oncologist or your primary care physician. Get to a pelvic floor therapist to find out what is impacting your pelvic floor muscles so you can create a plan to improve it. Remember, a pelvic floor therapist will present options best for you, and you are always in control. Our expert guest, Erica Vitek's favorite pelvic floor resources include IntimateRose.com, pelvicfloorstore.com, cmtmedical.com, and carolynmcmanus.com for mindfulness. You will find all of these links in the show notes or video description box. As always, thank you for sharing your time with me today. I hope you found it beneficial. And care for yourself like you are the most important person on this planet, because you are. And exercise like your life depends on it, because it does. We'll talk again soon.